Hello everyone. I am Swarnabharti Katti, graduate student masters in health and bioinformatics, and now I'm going to present the topic when the virus stays, that is the mystery of long COVID. And I'll walk you through some of the most complex challenges that emerged from the pandemic and the thing that followed, long COVID. So in this presentation, I am going to discuss about what happens behind the scenes, what are the mechanisms of long COVID, and what are the investigations to be done to diagnose it as a long COVID, what are the drug trials that have been done so far, and what are the treatment support that we can give to the long COVID patients who are suffering from it. We all know what the devil of the decade has done, the COVID, the pandemic. But the most intriguing part is the after effects of the people who have been affected directly or indirectly by it, called long COVID. Well, long COVID is an umbrella term that is used to describe symptoms that are beyond 12 weeks, even after you're affected by COVID. There have been like various terms that have been given to COVID, and they are called as post sequelae of COVID-19, COVID-19 syndrome, which is given by Institute of Health and Care Excellence, and the clinical trajectory and prognosis of long COVID is highly variable. But the working age adults are the most affected, with fatigue, with brain fog, and breathlessness being most common. So when you say long COVID, it is not categorically divided into a single symptom. There are a cluster of symptoms that are present here and that you see on this slide, from fatigue, from brain fog, breathlessness, dizziness, cough, anxiety, low mood, sore throat, skin rashes, sleep disturbances, palpitations, tinnitus, chest and body pains, fever, body weakness, gastrointestinal problems. It is not necessary that all of these symptoms occur at the same time, but they are chronic and they occur over a period of time. In this slide, we are going to discuss about the mechanisms of long COVID. When we talk about the multifaceted range of the clusters of symptoms that happen in long COVID, it is obvious that not only single mechanism can be unified or defined to cause the long COVID. So there are various kinds of mechanisms that happen, like immune dysregulation, viral persistence, organ dysfunction, microclots, metabolic disturbance, and mast cell activation, as you see on this slide. But when you talk about immune dysregulation, it is seen in the patients that have been post-hospitalized in UK, according to the article, and they have been observed with elevated levels of interleukin-6 and tumor necrosis factor. When we talk about organ dysfunction, you see that the organ's functionality has not been affected, but there are MRI abnormalities that have been seen upon investigation. When you talk about microclots and coagulation, we see that fibrin clots are observed in microvessels when investigated. And viral persistence is the presence of the protein fragments spike-like, which are found in the blood in the patients who have been affected with COVID priorly. And metabolic disturbances are caused by mitochondrial dysfunction, which leads to low energy and the low mood levels. And this is the main reason for the fatigue. It might be probably. And the mast cell activation is flushing, wheezing, and rapid, heavy breathing, which is caused by mast cell activation that links to the allergies and the skin rashes that have been seen in the symptoms in the before slide. So when we talk about long COVID having so many symptoms and so many mechanisms, how do we finally diagnose it to be long COVID? The first step we need to do is rule out all the other conditions that the patient might have. Like we need to do all the blood tests initially to confirm whether the patient has any other conditions like anemia, like vitamin deficiency, like thyroid stimulating hormone tests that diagnose any thyroid conditions to the patient. We need to also assess the sleep quality of the patient. If the patient has poor sleep or has any a low mood, a low anxiety things in the step 3 where we evaluate low mood or low anxiety. And we need also to assess if the patient is suffering from a type of boom bust activity cycle, which is like moments and periods of overexertion and over work and burnout, which are followed by chronic fatigue and no energy levels to do anything. Fatigue, and with brain fog, there are other symptoms like breathlessness and cardiac symptoms presented by patients. So that is the time when chest x-ray has to be done. Because breathlessness affects around 50% of patients, although breathing pattern disorder is a common cause for this symptom. Asthma can be ruled out, and if the patient has chronic obstructive pulmonary disorder, even that has to be ruled out. We should do spirometry and functional expired uh, nitric oxide can be useful if available, and or a peak flow if asthma is a possibility. If a chest X-ray is abnormal, then computed tomography has to be done. And to be clarify the nature of the abnormality, lung fibrosis from COVID pneumonia is well recognized and represent the footprint of the infection located in areas of previous acute lung abnormality. It does not appear as immediately, but and over time and as a progressive disorder, lung fibrosis can occur, and this is the alternative disease etiology other than long COVID. Although acute COVID pneumonia is associated with prothrombic state, pulmonary emboli are not commonly identified clinically in patients who are not hospitalized, and dysautonomia or autonomic dysregulation resulting in inappropriate sinus tachycardia, postural hypotension. Many of these factors do occur in long COVID patients. So these range of symptoms, including dizziness, headache, fatigue, and exercise intolerance, must be seen. If the if all these are outruled, then we also have to suggest the patient to have an ECG, that is electrocardiogram, and see if the patient has any dizziness upon waking or hypertension upon waking with the NASA lean test. Uh, so when we talk about different kinds of pathophysiological processes that are responsible for long COVID and different kinds of symptoms, it is obvious that not only one drug is responsible to cure it, and there is no single cure or medication or treatment for long COVID. It is just that repurposing of different kinds of drugs that have already been established to cure the symptoms or to reduce the symptoms and fatigue. Uh, Primarily. We see in this chart there is a kind of drugs which have been done in the studies, like stimulate ICP, which targeted the microclots to low level inflammation, and the results are awaited yet while the article was being written. And ritonavir is a kind of drug which is an antiviral combo, and no difference was seen in the patients who were under the trial. And nirma is also an antiviral to reduce the viral replication, and in this case, reduced risk of organ damage was seen, which is a good thing. AXA 1125 is also a drug which is used for mitochondrial support, and it did improve fatigue, but there was no MRI change. Coenzyme Q10 was a drug and which is used to improve mitochondrial function, but there was no benefit seen in symptoms. And metformin, the most famous drug, is used for the prevention of long COVID for the patients who have been already affected by it. And there was 6.3% people who developed long COVID when compared with the 10.4% of the placebo. So when we discussed about the innumerable pathophysiological process responsible for long COVID and different kinds of drug trades that have been done so far, it is obviously understood that there is no single treatment for long COVID and patients suffering from it. But we do have treatments that are multifaceted in a way of approach, and different kinds of symptoms have to be subdued and reduced with different kinds of symptoms applied clinically. So, the most important symptom and most common symptom a patient from long COVID refers to is fatigue. The one thing we can do here is do energy pacing and avoid any overexertion. When we are talking, according to this article, that most of the working adults have been affected, this means that the patient has to undergo hybrid kind of work before they go through a full day and full time kind of work from 9 to 10 hours. It is very important to limit themselves from overexerting and burning out. If the patient has any breathlessness, then breathing training has to be done. It then asthma or any uh, chronic obstructive pulmonary disorder have to be medicated. They have to be controlled with help of medication. And we also know about dysautonomia. So this is the condition where autonomic dysregulation occurs and is common in very much in long COVID. It is usually refers to as the abnormalities of the heart and the blood pressure, heart activities and the blood pressure, and and we have seen there is a fall in blood pressure for many kinds of patients. So this is the time where the patient has to take a lot of hydration. They have to take intake of salt. The hydration might be up to 2 to 3 liters, and loose garments have to be worn. They should not be overexerted and overburnt out, and they should take care of their blood pressure. And if the brain fog and memory aids are seen in the patient, we have to do task organization, not to overexert ourselves, and not undergo any anxiety disorders. And all this occurs in a patient in long COVID when you have no energy and no uh, strength to do work. This will cause mental health problems. Then mental health counseling is the first thing the patient has to undergo, accepting that long COVID is not fake term. Long COVID is real and long COVID is complex. Medication has to be given if the patient is undergoing any kind of clinical symptoms and any kind of breathlessness or blood pressure or cardiac symptoms, and returning to work has to be gradual and not immediately after patient has been affected with COVID and after that with long COVID. Uh, Bouts of uh, work activities have to be done, but periods of rest have also be taken. This has brought us to the end of the presentation, and this made it clear that long COVID is no longer uh, a term that is used to define only the fatigue and the chronic pain the patient has, but it is real, it is persistent, and it is complex. Clinical evaluation must be patient-centered and not based solely upon blood tests, but also the mental health of the patient and anxiety disorders. The drug trials are underway, but functional support is essential. Education, awareness, and ongoing research hold the key. This has brought us to the end of the presentation. I thank everyone for giving me this opportunity to present on Student Scholars Day. This is a great opportunity to make people aware about long COVID and symptoms. Uh, Feel free to give your feedback and any questions you might have with this QR code, and also definitely refer to this amazing article about long COVID. Thank you.